Good morning from Miami Beach. This is Dr. John Bennett broadcasting from the sumptuous studios of Neurosurgical TV. Today we have the honor of having Nathalie Ghomsi, not a medical student. She just finished medical school. She's a practicing physician,
Yes.
and is a practicing physician in Cameroon. First, let's meet the distinguished panelists. First, we'll start with Khalif. Good day, Khalif.
Good evening, everybody. Greetings from Nairobi, Kenya. My name is Dr. Khalif. I'm a fellow in neurosurgery in the College of Surgeons of East Central and Southern Africa at Aga Khan University Hospital, Nairobi, and I am glad to be here.
Yeah, and we're working with Dr. Khalif to try to establish a cadaver lab, an online cadaver lab, and hopefully we'll see where that goes. And welcome, Dr. Kabulo.
Thank you so much. My name is Kabulo. I'm final year neurosurgery resident at the University of Zimbabwe, but I'm originally from Congo.
And a frequent participant in our activities. Thank you, Dr. Kabulo. And Arsene, can you please introduce yourself?
Hello, Dr. John. I'm Arsene Daniels from Republic Democratic of Congo. I'm a medical student in final year.
Very good. Welcome. Okay, Nathalie, it's all yours, and thank you very much.
Okay, thank you everyone for honoring me in this presentation. Today I'm going to present on the basal ganglia and related nuclei. So, basal ganglia and related nuclei. In order to go through our presentation, we'll follow the plan. After a brief introduction, we'll give the anatomy of the basal nuclei. It will follow the anatomy of related nuclei, clinical significance, surgical treatment, and its conclusion.
Okay.
Basal nuclei are referred to as a complex of gray matter found within the different hemispheres of the cerebrum. It plays a critical role in the integration of motor activity and the control of posture.
Yeah, excuse me, Nathalie, are you screen sharing now? We're not seeing a screen share.
You're not seeing? Oh, sorry.
No, we're not seeing it.
Let me stop the video first. Then let me do this.
Take your time. We can edit this out.
Okay. I don't know.
There you go.
Up?
Not yet. Not yet. No, not quite. Take your time. You've done it before.
Yeah.
Okay, very good.
Okay.
Okay, basal ganglia. Okay. And you want to make that.
So
Excellent, excellent.
Okay. So I was saying today we'll present on the basal ganglia and related nuclei. In order to go through our presentation, we'll follow this plan. After a brief introduction, we'll go through the anatomy of the basal nuclei, the related nuclei. We'll give some clinical significance and some surgical treatment, and then we'll conclude. Basal nuclei are referred to as a complex of gray matter found, nuclear gray matter found within the cerebral hemispheres. They play a critical role in the integration of motor activity and the control of posture. They act at the interface between the sensory and the motor systems. They integrate and process input from the cerebral cortex and send modified signals to the thalamus, which after further alteration relays the output back to the specific areas of the cerebral cortex where it came from. The corpus creatum, the amygdalic body, and the claustrum forms the basal ganglia, and these ganglia are related to other nuclei. We have the subthalamic nucleus, which comes from the diencephalon. We have the substantia nigra, which comes from the midbrain, and we have the pedunculopontine nuclei, which comes from the pons. The coded, usually in some classifications, you find people calling some parts the striatum. Actually, the association between the coded nucleus and the putamen is called the striatum. This is because the putamen and the coded nucleus have similarities in their functions, in their phylogenetic, and in their connections. You also find the term lenticular nucleus. The globus pallidus and the putamen forms the lenticular nucleus. We have a lenticular shaped mass, gray matter mass. They are called so because they are found just next to each other, but they don't have any particular connection, particular functional and connective similarity. As you can see here, we have the different basal ganglia. We have the body of the coded nucleus, which you find here. We have the putamen, which is related, the putamen, which is found just beneath the coded nucleus and is separated from it by the internal capsule. We have the globus pallidus, which is much more internal to the putamen. We have the amygdala, which ends the tail of the coded nucleus, and then we have the related nuclei, nuclei, among which the subthalamic nucleus, which is usually found under the thalamus. We have the substantia nigra, which is found at the level of the midbrain. This is a coronal section of the brain with a Milligan stain, which shows different parts of different basal ganglia. We have here the head of the coded nucleus. We have the claustrum. The claustrum is just gray matter, which is found between the insula and the putamen. We have the globus pallidus, which is much more internal to the putamen. We have the thalamus. We have the thalamus and the basal ganglia controls automatic associated movements. They plan and program voluntary movements. They determine the rapidity and the length of the movement. They decrease and regulate muscle tone and inhibit unwanted muscular activity. They also control reflex muscular activity. They also take part in the physical expression, behavior, and emotional states through their link with the nucleus accumbens, which is found just beneath the coded nucleus, and which links the coded nucleus with the striatum. This nucleus accumbens has a similar connection to the rest of the striatum and also links to the amygdaloid, thus providing an important link between the basal ganglia and the limbic system. We have this classification of the basal ganglia, which is initially called the corpus striatum. The corpus striatum is divided into the striatum, which is also known as neostriatum, that's the newest striatum, and the globus pallidus, also called pallius striatum, which is called ancient, which is also called ancient striatum. The striatum is made up of the coded nucleus and the putamen dorsally, and the nucleus accumbens ventrally. The globus pallidus has two main parts. We have dorsally, we have the internal segment and the external segments. We also have the ventral pallidum. It's divided into two parts. We have the pars compacta and the pars reticulata. We will see that more detailedly later. Then let's get to the anatomy. We'll start by the coded nucleus. The coded nucleus is a comma-shaped nuclei, which is made up of a head found in the frontal lobe, a body which take part in the lateral wall of the lateral ventricle, and a tail which is found in the temporal lobe. It receives blood supply from the lenticular-striated arteries, and the anterior choroidal arteries. It is made up of dopaminergic neurons, projecting neurons. The head has a round shape. The head has a rounded shape, is rounded in shape, with a large anterior end in front of the interventricular foramen. It bulges into the floor and lateral wall of the anterior horn of the lateral of the lateral ventricle, and it is related laterally with the anterior limb of the internal capsule, which separates it from the lenticular nuclei. Below the anterior limb, we have a band of gray matter which connects the putamen with the lenticular nucleus called the nucleus accumbens. The body of the caudate nucleus is long and narrow. It forms the floor of the central part of the lateral ventricle. It is separated from the thalamus by the stria terminalis and the thalamus striated vein. Its tail is long and slender. It runs down and forward. It forms the roof of the horn of the lateral ventricle and terminates anteriorly in the amygdaloid body. It is related above with the thalamus, separated from it separated from the sublenticular part of the internal capsule. The globus pallidus is separated by the external capsule from the tail of the caudate nucleus. We have to note that the nucleus accumbens is associated with a reward and gratification, and is believed to be part of the mechanism underlying addictive aspects of behavior, including being an important site of action of addictive substance, such as cocaine, marijuana, and else, etc. The caudate nucleus is linked upward. The caudate nucleus upward forms the lateral wall of the anterior horn of the lateral ventricle, and it is separated from the putamen by the internal capsule, except rostrally, where it is in contact with the putamen through the nucleus accumbens. We will talk secondly about the putamen. The putamen is found lateral to the globus pallidus. Lateral to the globus pallidus. More externally to it lies a white matter which sandwiches a gray matter, a band of gray matter going upward and medially called the claustrum. It is separated from separates the white matter into two capsules. We have the external capsules, which is medial to the claustrum, and we have the extreme capsule, which is medial to the insula. The globus pallidus has two portions. We have the internal globus pallidus, which is separated from the external globus pallidus by a thin lamina of fibers, of neuron fibers, called the thin lamina of neuron fibers called the lateral medulla, the medial medullary lamina. The globus pallidus external, that's the one which is on the image, which is orange, is separated from the putamen by the lateral medullary lamina. Functionally, the ventral pallidum receives efferent connections from the ventral part of the ventral striatum. That's the nucleus accumbens and the olfactory tubercles. They then project to the dorsomedial nucleus of the dorsal thalamus, which projects to the prefrontal cortex, the pedunculopontine nucleus, and the tegmental motor areas. Their function is to plan and inhibit movements from the dorsal striatopallidal complex. This has been explained further. The claustrum, then we have the claustrum. Firstly, we have the claustrum. The claustrum is this thin gray matter sandwiched between these two white matters. It is found medial to the insula and lateral to the putamen. It continues anteriorly with the anterior perforated substance and the amygdaloid body. Sometimes they say the claustrum may be detached from the insular cortex or from the corpus striatum, or sometimes both. Their connections and functions are not properly known till date. We then have the amygdaloid body. We shall not too much extend on the amygdaloid body because the amygdala body takes part mostly in the system, in the limbic system, functionally in the limbic system. It is an almond-shaped mass of gray matter which is found in the temporal lobe at the level of the deep into the uncus. We shall now pass to the related nuclei. We have three main related nuclei that we will talk about. We have the substantia nigra. The substantia nigra is the largest nucleus in the midbrain. It lies dorsally to the cerebral peduncle, and it's mainly made up of dopamine. It is made up of two parts. We have the pars compacta and the pars reticulata. The substantia nigra, it's called so because it is made up of dopaminergic because it is made up of mainly dopaminergic, rich in melanin neurons, giving its color this darkish color of the pars compacta. The next image will better explain. We have here the pars reticulata, which is found laterally to the pars compacta. As you can see on the image, the pars compacta is much more darker than the pars reticulata. This is due to the dopamine neurons, which is rich in melanin. The pars reticulata has strong structural and functional resemblance to the globus pallidus internal and is separated from it by the internal capsule. It is rich in GABAergic neurons. These GABAergic neurons fire simultaneously fire action potentials. The purpose of this simultaneous action potential is to inhibit the target of basal ganglia and decrease the inhibition associated with movement. The subthalamic nucleus gives them excitatory inputs that modulates the rate of firing of this spontaneous action potentials. We have the pars reticulata. The pars reticulata is found medially to the pars. The pars compacta is found medially to the pars reticulata. It sends excitatory impulse to the striatum via D1 pathway. The D1 pathway is the direct pathway. We'll talk that further. That excites and activates the striatum, resulting in the release of GABA onto the globus pallidus to inhibit its inhibitory effect on the thalamus. This causes a thalamocortical pathway to become excited and transmit motor neuron signals to cerebral cortex to allow the initiation of movements. Spatial learning, the observation about one's environment and location in space. The pars reticulata is also suspected to regulate sleep-wake cycle. Secondly, we have the subthalamic nucleus. The subthalamic nucleus is a massive biconvex lens-shaped nucleus which is located under the thalamus, behind the substantia nigra and medial to the internal capsule. A target site, it is a main target site for the treatment of Parkinson's disease. It is mainly made up of glutamatergic neurons, and its main function is to control impulses and compulsory actions. Thirdly, we have the pedunculopontine nucleus. The pedunculopontine nucleus is a collection of neurons located at the upper pons. They lie under the substantia nigra and are adjacent to the superior cerebellar peduncles. They are made up of two parts. We have the pars compacta, which is cholinergic, and we have the pars dissipata, which is glutamatergic. One of the main components, it is one of the main components of the reticular activating system. This pedunculopontine nucleus projects to many structures. They project to basal ganglia, particularly to the subthalamus nucleus, the pars compacta of the substantia nigra, and the internal globus pallidus. They also project to the thalamus, to the cerebellum, and the lower brain stem. Its functions include the arousal, attention, learning, reward, and voluntary and voluntary limb movement and locomotion. We then pass to the connections of the basal ganglia. To talk of connections, we have to know that in any connection in the brain, we have the afferent connections and the efferent connections. The afferent connections of the basal ganglia is mostly made up of the cerebral cortex, the thalamus, the substantia nigra, while the efferent connections are mostly made up of the striatopyramidal, sorry. On the left, we have the different connections which are being efferent. As we said before, we have the striatonigral GABA and acetylcholine neurons. We have the striatopyramidal GABAergic neurons. We also have these connections between the globus pallidus, which connects from the globus pallidus, these fibers which is sent from the globus pallidus directly to the thalamus. We have the ansal and trace. From the loops will go through the posterior limb of the internal capsule directly into the ventral anterior and ventral lateral thalamus. Before getting there, they will connect together at the level of just next to the thalamus to form one fasciculus called the thalamic fasciculus, alongside with the cerebropontine fasciculus. There we are going to explain the different connections, the basal ganglia have with the different processes, and we will give their roles in order to explain better their clinical significance. In the direct pathway, as said before, it's a pathway which leads directly from the cortex. It's a corticostriatopyramidal pathway. The cortex will project to the striatum using exciting neurotransmitters, which is like glutamatergic. This will excite the striatal neurons, particularly the medium spiny striatal neurons, which in turn projects to the internal globus pallidus using the GABAergic medium spiny striatal neurons. This will have an effect to excite more, to inhibit it. This will inhibit the effect of the globus pallidus on the thalamus, and the thalamus on the ventral anterior and ventral lateral motor thalamus. Hence, the consequence of this pathway is to increase the excitatory thalamic input to the cortex. That is, it will turn up motor activities. While on the other hand, we also have the indirect pathway. In the indirect pathway, the cortex projects excitatory neurons onto the striatum, which in turn projects instead to the globus pallidus external, giving an inhibitory effect on this globus pallidus external. This inhibitory effect, this will cause a reduction of protection to the subthalamic nuclei. The subthalamic nuclei, which is made up of, as we said earlier, of glutamatergic excitatory neurons. This will send in turn projects to the globus pallidus internal and give an excitatory effect on the globus pallidus internal globus pallidus. The internal globus pallidus, being made up of GABAergic neurons, will send a high quantity of inhibitory neurons, GABAergic neurons, to the thalamic, to the motor thalamic nuclei. The result of this will be a decrease in the excitatory thalamic input to the cortex, then hence turning down the motor activity. In this second image, we have the substantia nigra, the different pathways of the substantia nigra. The substantia nigra, as said before, has two parts. We have the pars compacta and the pars reticulata. The pars compacta is made up of dopaminergic neurons, which are excitatory neurons, while the pars reticulata is made up of cholinergic neurons, which are inhibitory neurons. The pars compacta also projects to the striatum, giving an excitatory effect on the striatum. That's a projection of high quantities of GABAergic interneurons to the globus pallidus internal or the globus pallidus external, which will continue as the same pathway that we earlier explained before. We have to note that I'm sorry to be a little bit because it's a little bit confusing, but the substantia nigra, the subthalamic nuclei, are other organs which also projects and gives either excitatory stimulus to basal ganglia for the control of movement. Other one that should be noted here is that the substantia nigra, the dopaminergic part, that's the pars compacta of the substantia nigra, will tend to turn up the direct pathway and turn down the indirect pathway. This will increase the motor activity. While the striatal interneuron, that's the substantia nigra, the cholinergic part of the substantia nigra, will turn to turn down the direct pathway and turn up the indirect pathway. This will turn to decrease the motor activity. This is the same image, which is globalizing all the different inputs and outputs in the basal ganglia. We have, as we said before, the substantia nigra, which will send the substantia nigra, which will send excitatory impulse to the putamen, to the striatum, which in turn send inhibitory impulse to the globus pallidus external and the globus pallidus internal. While the globus pallidus internal will directly send a lesser inhibitory impulse to the thalamus, the globus pallidus external will instead pass through the subthalamic nucleus, which is dopaminergic, and will send then excitatory impulse to the globus pallidus internal, which will go back to which will be more inhibitory on the thalamus, and then will inhibit movements from the different cortices.
Okay.
So, significance. We have different movement disorders which could be created if there are lesions of this basal ganglia. We have atetosis, which is a lesion in the globus pallidus, particularly globus pallidus externa. We have hemibalismus, which will be caused by a lesion in the subthalamic nuclei. We have the chorea, Huntington chorea, which will be caused by a lesion in the caudal nucleus, and we have the Parkinson's disease, which can be caused by a lesion in the substantia nigra, particularly the pars compacta. in the Parkinson's disease, there is a degeneration of the neurons in the pars compacta. This will give a less excitatory impulse on the striatum, hence causing now the striatum to be more inhibitory on the external globus pallidus, or more inhibitory on the globe, or less inhibitory on the internal globus pallidus. This will cause an increase in the inhibitory effect of the thalamus, and hence on the causes. That's why we have these patients who have slow movement. They are hypokinetic. They have tremor, especially when they want to have when they do voluntary movements. They will do voluntary movements. This is an image which shows the degeneration of the substantia nigra, particularly the pars reticulata, which we said was more medial. It was found medial to the pars reticulata. So we have this patient who have a stooped posture. He has a rigidity due to the increase in the tonus of the muscles. We have hand tremor, and we have a patient who have slow movements, slow stepped movements. So from years now, surgical treatment is still and has been discussed on the treatment of these different extrapyramidal syndromes, amongst which we retain 3 from different articles. We have an ablative surgery, which could be done by pallidotomy. Pallidotomy is a tiny electrical probe. It's when a tiny electrical probe is placed in the globus pallidus, which then is heated at 80 degrees for 60 seconds to destroy the small area of the brain. That's the pallidal area of the brain. We could also do a thalamotomy, which is not really done, or no more done today. We could also do the deep brain stimulus, particularly the subthalamic deep brain stimulus. It is mostly done. The latest treatment being used to treat this kind of patient is the grafting of fetal mesencephalic cell into the striatum. The aims of this treatment, the pallidotomy and the DBS, is to reduce the excessive inhibitory output of the globus pallidus internal and the pars reticular substantia nigra. It reverses the pathophysiological consequences of the dopamine deficiency in the pallidus striatum. These are some images of how the thalamotomy and the pallidotomy could be done. Usually they use stereotactic radiation to hit either the pallidum or the thalamus. This is an example of how the deep brain stimulus is being done, particularly the subthalamic nucleus deep brain stimulus. We will deliver an electrical pulse to the precise target, that's the subthalamic nucleus. This procedure is done under MRI and computer control. The heads are inserted through holes in the skull. Extension wires are threaded under the skin and down the side of the patient's head, as we can see up. And then connected to a battery back implanted in the chest. It serves like if you can say, a pacemaker which will be used to regularize neurotransmission. The main indications of surgical treatment are patients with severe bilateral problems with uncontrollable with presence of pharmacological tools. thalamotomy is rarely indicated, but it can usually be done in patients who have long-standing trauma which resist to drugs. To conclude, we say that basal ganglia is a complex of nuclei found within each hemisphere. It helps regulate the intensity of movement and locomotion. A disorder of one of these ganglia will lead to either a hypokinetic or hyperkinetic voluntary movements. The indications of surgical treatment should be the last resource used for patients. In LMICs like our country, we still use medical treatment due to non-availability of appropriate equipment. Thank you for your attention. It's okay. It's finished.
Thank you so much.
Okay, I'm sorry. Okay, I'm sorry, Khalif. There, I fell asleep at the wheel. Thank you, Nathalie. We'll immediately turn it over to the panel for comments. Any comments or questions from the panelists?
Well, I think that's a good presentation. As far as anatomy is concerned, it's a very complex region of the brain with a lot of pathology and a lot of new things going on, such as DBS and all the other things that Nathalie has mentioned. Yeah, if you look at Nathalie, if you look at there's a link I shared. There's a YouTube video of high resolution MRI. I'll try to share my.
Okay, let me. Only one person can share. Let me get that.
Okay.
Okay, it's open. It's open. It should be open. Well, Nathalie, I'm trying to. Can you get off the screen share, Nathalie, please?
Let me just do it.
Yeah, just.
I have a problem with my machine.
Yeah.
Yeah.
I might be able to do it from my end here. Let me get.
You can see it on my screen?
Yes, yes.
Yeah, so if you just follow this is apparently an MRI that took 100 hours to be done on a patient who died and the relatives donated the service. So if you can go through the MRI and then you show us the anatomy, that would be lovely. Like that would be the head of the caudate. That's where it goes all the way down. That is the thalamus. Yeah, it's a very beautiful anatomy. Can you do that for us, Nathalie?
Well, boy, that's a great teaching tool.
Hello?
Yes, we can hear you.
Yeah, Natalia.
Natalia, there? Nathalie? She may.
Nathalie.
Yeah, she may have been bumped off sometimes with the. Let me see here.
Yeah.
Nathalie. Yeah, she's there. There she is.
Yeah, sorry. Yes.
Go ahead.
Yeah.
Go ahead.
The connection is not great.
Nathalie's there.
Yeah. So
it's okay. I'm there. Doctor.
So yeah, we also need to learn radiological anatomy, which is very important.
Okay.
And especially MRI, you can identify all those structures in patients with Parkinsonism, the pathology of the substantia nigra, and basically the basal ganglia is evident. Yeah. So
okay.
You can make that screen bigger, Dr. Khalif.
I think that's
Yeah, make it bigger there. Yeah, you can make that. Yeah, there we go.
Yeah.
That's much better.
So yeah. So we'll also need to learn the radiological anatomy because as surgeons, that's what we rely most on. The other thing we should have talked about is hypertensive bleeds and how they affect this region. It's one of the most common areas that we get hypertensive patients present with hemiparesis. Most of the cases, we've got at least 4 or 5 patients with that diagnosis at the moment. Basal ganglia bleed secondary to hypertension. Yeah, so just you to have a look at MRI and then appreciate all the structure that you mentioned morphologically. Yeah.
This 100 micron MRI, is this new?
This is new. This is from Massachusetts. and it took 100 hours apparently to be done.
It's a good teaching tool, huh?
It is for neuroradiology.
It's only on
We can actually see all those
so-
not shared.
So those are fine cuts, right? Very fine cuts.
Yeah.
Please, John, can I make my own comment?
Okay.
What I wanted to say is I find it really difficult explaining the interconnections. Maybe the thing is inside the explanation is inside the head, but it's not. I don't know, maybe because I'm a francophone initially, but it's not really flowing. That's I want to know if there's another way to, how can I explain it more simply? Because even when I read in books, when they try to explain, they explain it differently, but they want to say the same thing. So far as you have the great idea behind the head, but when you can't explain it, it's a little bit. That's why I was just I was stopped when I wanted to explain the connections.
Yeah.
I don't know if
Did you hear what she said, Khalif?
Yeah, that the different books explain it differently.
Okay.
Is that what you say, Nathalie?
yes, and so it's not easily the main idea is the same, but you don't know what to use to explain better or to as the output is a little bit difficult. The input is okay, but the output is a little bit difficult. That's how I can explain that better.
Yeah, I agree. It's a complex physiology.
But I think we need to know it because it's the main idea behind the treatment, the different treatments, surgical treatment, and also pharmacologic treatments. So,
Yeah.
Okay. I believe. Okay. I believe Dr. Kabulo was going to present some cases regarding this. Dr. Kabulo, you there?
Hello, John.
Yes.
Hey, Naru, how you doing? I think welcome. I think Dr. Kabulo mentioned he was going to present a few cases having to do with what Nathalie just went over. Dr. Kabulo, are you there?
Yes, I'm there.
Okay,
Dr. Bennett?
you're going to present something regarding Nathalie's presentation?
Yes, I wanted just to give a few comments on what Nathalie presented.
Okay.
I wanted to add more cases, but I had problems. I didn't manage to get the pictures of those patients.
Okay.
So what I'm going to do here, I will just try to emphasize on semiology, on what she mentioned. Then I will just go on those signs like aticosis, myoclonus. So how do you describe them? So I'll just go details on those things. So it was a good presentation, Dr. Nathalie. I enjoyed it. To understand basal ganglia, it's not easy because there are many connections. The physiology, especially, it's not easy because I think I will send you one book where you can read and understand those things. Firstly, what I wanted to say is basal ganglia is a misnomer. That's not the correct name. The misnomer, they are basal nuclei. Because in central nervous system, we call ganglia the collection of cell bodies outside the. Sorry, who's sharing the screen?
Oh, Dr. Naru, you're taking the screen over. Dr. Naru.
Nuro.
Okay, that's okay. That's all right.
Yes.
That's okay.
It's okay. So let me do this so Nuru won't come again.
Okay. If Naru lets us.
Yes. Yeah. So I was saying, basal ganglia. I can hear another sound there. Maybe someone is double.
Okay. Yeah. Let me mute other people that aren't. Okay. Okay. Should be okay.
It's okay. So I said ganglia, basal ganglia is a misnomer. That's not the correct name. Normally, we should call them basal nuclei because ganglia means collection of cell bodies outside the central nervous system. And nuclei means collection of cell body inside the central nervous system. So normally we should call them basal nuclei. Basal ganglia is a misnomer. So like Dr. Nathalie mentioned, I'm not going to take too much time. I will just take few slides. I don't know if you can see my screen. Can you see my screen?
We can see it, we can see it.
Yeah, we see the basal ganglia slide. Oh, there we go. There we go.
Like I was saying, there are structures, neurostructures, which are involved in control of the movement, like the motor cortex, the brainstem, the basal ganglia, the cerebellum, and the spinal cord. So those are the neurostructures which are involved in control of the movement. So here we are just talking about basal ganglia. Like this is the anatomy Dr. Nathalie mentioned. And here it's like what Dr. Khalif mentioned. So we should also talk about hypertensive bleed. Usually we get hypertensive bleed around the basal ganglia because those small arteries which are supplying these structures, those lenticulostriate arteries, they are too small but coming from a high velocity artery. They are branches of the middle cerebral artery, but small arteries coming from a big artery. With a high pressure, they tend to burst and give you a basal ganglia bleed. So usually hypertensive patient, the first thing we look is a bleed around the basal ganglia. So this is how they look, like Dr. Khalif showed. And this picture down on the left is just showing basal ganglia bleed without intraventricular extension. And the next one is just showing basal ganglia bleed with intraventricular extension. This is especially in case of hypertension, like Dr. Khalif mentioned. So there are several connections, like Nathalie mentioned. I'm not going through those connections, but there are things. There are two loops. There is a direct loop and indirect loop, like Nathalie mentioned. So the direct loop begins with the neurons in the striatum that contain the GABA and substance P, and they increase activity of striatal neurons, which leads to disinhibition of thalamic neurons. And therefore, they increase stimulation of the cerebral cortex. That's the direct loop. And the indirect loop includes the subthalamic nuclei and the activity of the striatal GABA and the NK neurons, so which result in inhibition of the thalamic and the reduced stimulation of the cortex. So the end, by the end of the day, for these two loops, the direct one is ending by stimulating the cortex, and the indirect one is reducing the stimulation of the cortex. Like you can see here in green, it's the direct loop, and in blue, it's the indirect loop. So there are also other channels apart from the motor. What I'm going to emphasize is about dyskinesia and the corpus striatum. So there is what we call choreiform movements. These are movements which involve multiple muscles. They are brisk, they are jerky, and they are purposeless. But these movements are also irregularly timed and most pronounced in the upper limbs and face, but cannot be voluntarily inhibited. They come, you can't inhibit them, they are there, but purposeless movement. Then the next one, dystonic movement. They are sustained contractions that lead to abnormal posture or twisting of the neck, trunk, or lower limb. And they say dystonia musculorum deformans, also called generalized dystonia, which is a particularly disabling motor disturbance in which slow or reading involuntary movement of the axial and the limb musculature are sustained, leading in rare cases to permanent contractures. So, and the most common dystonia is spasmodic torticollis, which is rotating the neck laterally and in flexion. The athetosis, it's type of dystonia in which there is slow and sinuous movement, which is involving the proximal and distal musculature of the limbs. Then myoclonus, these consist of sudden, repetitive, isolated, strong contractions, which are also rhythmic and regularly alternating movement of small amplitude constitute tremor. And when they are stereotyped, purposeless movement that occur at random, then they are called tics. A generalized inability to be still with constant motion of limbs is sometimes called akathisia. So then the largest involuntary movement are those of balism. They're saying an exaggerated form of chorea in which the limbs make large, irregular flinging and rotational movements caused by contraction of movement of muscles acting on the shoulder or hip. You see a patient like, they say the most common type of balism is hemibalism. You see the patient moving purposely the upper or lower limb, but the movement, it's like a rotational movement from the shoulder. The base of that movement is like on the shoulder and the hip. There is a video here. I don't know if it is going to play and show you. Okay. Can you see the video? Is it clear?
Yeah, yes. Well, it's a little unclear right there, but give it a second.
Okay.
Is it clear for anybody else?
Is it clear for anybody else?
Not really clear.
Can increase the screen size.
Yeah, maybe increase the screen size. Dr. Gabulo, can you increase the screen size? Right now it's small. If you can,
Oh yeah, there you go.
Yeah, if you increase the screen size.
Play now.
Put it in a full screen.
Yeah, at the bottom of the screen, there's some options on the WordPress, on the PowerPoint screen. At the bottom, there's a couple of options to make the screen bigger. Next to notes and comments. You see, you see at the bottom
full
of
screen.
Yeah, at the bottom of the
on F5 on his keyboard.
Okay. To press what?
F5 on your keyboard.
F5.
F5.
And then play the
okay,
video.
Did you hear that, Dr. Kabul? F5.
F5, yes.
Okay, well, oh my God, is that a magical solution? Let's see.
Unfortunately.
There we go. That's good. That's great.
Go to
F5. Okay, F5. Okay, you can see it, Dr. Kabul, right?
Let me go back to that slide. Okay, I think I'm close by. Okay. Yes.
Yes. Oh, there we go. Okay.
I don't know. Is it playing now?
No, not yet. It may be difficult because it takes a lot of bandwidth to play a video, Dr. Gabulo.
Unfortunately.
Yeah, unless you're at a high-speed connection, it might be difficult.
Yes, unfortunately, I wanted to show those
movements, obviously, the movements, right?
on the
The
video, but
tremors,
unfortunately-
etc.
So yes, like
Okay,
I
I
was
guess you have to
saying,
describe them.
these disorders of the motor circuit of the basal ganglia, they can include like the Parkinson. Sorry.
Go ahead.
If you let me share that video for a second.
It's okay.
Let me try.
Oh, okay. Yeah.
I think this is the video.
Yeah, there you go.
Can you see?
Khalif, I think you should be a producer for Neurosurgical TV.
That's the hemibalismus. I think the same video.
That's the hemibalismus, yes. Like, okay.
Yeah, Jackie movement.
Yes.
Yeah.
Yes. Like you are seeing the video, I just combined also a video with the chorea, with myoclonus, but unfortunately.
Go ahead, Abdullah.
Yeah. So what I was saying, like these disorders, they can include like Parkinson's disease, where, like Nathalie said, there's degeneration of the nigral dopaminergic neurons, or Huntington's chorea, where there's degeneration or in the striatum and the Balis we are talking about, where you get the damage to subthalamic.
We can't see your screen, please.
Sorry?
Yeah, we can't see your screen. We've lost your screen.
Okay, I was almost done.
There you go. There you go. You got it.
Yeah.
Yes. Thank you. Yes, excellent.
Okay, I'm almost done. I wanted just to show those movements on the video. Unfortunately, it didn't go, but we saw the hemibalismus on the video shared by Dr. Khalif. So yeah, then I won't go deep on Parkinson's disease. But in brief, when we have hypokinetic disorders, it means there is insufficient of direct pathway output, but excess of indirect pathway output. Then with hyperkinetic, it's now the opposite. You get excess of direct pathway and insufficient of indirect pathway. I think I'll stop by there. Thank you so much.
Well, thanks, Dr. Gobolo. That was an added bonus to Nathalie's talk.